as both John Herzenberg and Dr. Birch mentioned, there's alignment and there's orientation. Alignment refers to the whole mechanical axis of the entire limb. Orientation, just simplistically, is how each bone is oriented in relationship to the adjacent joints. And then second thing that I think is commonly sometimes very loosely used is, well, this patient has a 10-degree flexion contracture, and he may have a 10-degree procurvatum deformity of the distal femur or proximal tibia. So try to be a little bit careful with that, you can, I think every contracture is a deformity, but not every deformity is a contracture. And that's, for some reason, people use it more in the sagittal plane than in the frontal plane. And also, I think part of the reason we don't give that much importance to the sagittal deformity is because it's better tolerated. All our joints in the lower extremity have more motion in the sagittal plane than they do in the coronal plane. And I think, again, as John mentioned, you got to watch for compensatory changes in adjacent bones and joints. And it's actually more common in the growing children. So always start with a physical exam, examine the entire extremity, including the spine. And for the purpose of this talk, we'll concentrate mostly around the knee and the hip. And again, this is a child with varus deformity. Not only look at it from the frontal view, but also from the side. So you could have a procurvatum deformity, which if you don't pick up clinically and or radiographically, you're going to leave somebody with an undercorrected problem. And in terms of leg length discrepancy, a lot of these children, not just with Blount's disease, but with a lot of, let's say, flexion deformities at the knees, will have an apparent shortening of the limb. So you just need to keep that in mind when you're treating it and assessing, a limb length problem. This is interesting, and show you some clinical anecdotes. This is an 8-year-old child with arthrogryposis, and she can barely stand and independently walk because she's got all these contractures in her lower extremities. And just focus on the spine for a second, and you can see she's got a lot of lumbar lordosis. So amongst the residents, you want to take a shot. What else could this be coming from? What could this lumbar lordosis be coming from? Go ahead, speak up. You're so quiet. Perfect, yeah. So it could have, and so how do you sort that out? How do you clinically assess whether this patient has, a flexible or a stiff lumbar spine? Okay. Okay, that's good. You can lay them prone. What else can you do? Right. So if you flex their hips or have them sit up, right, and if you see that the spine straightens out or actually the lordosis disappears, so that means a lot of that, so-called apparent lordosis was actually coming from the hips. Now, this is another kid. So similar kind of an exam, maybe a little more exaggerated, where she also has, contractures of her lower extremities, has hip contractures and, spinal lordosis, lumbar lordosis. But in this case, you can see it's a little different, that even with the hips flexed, she still has some residual lordosis. So I think it's good to sort that out, have that concept in mind, that, the hip is related to the spine in a lot of different ways. So this is one of them where you should look at the spine and the hips and sort out, be very comfortable with sorting out, what's primary, what's secondary, what's fixed, what's flexible. Going further with the clinical exam, again, you guys are experts at this, range of motion, ligamentous laxity. And another concept that it took a while for me to get my head around it, was this whole thing about, what do you need to have a stable gait? And, the basic thing is you want stability in stance and clearance in swing. And really there are three let me step back. To have the lower extremity muscles work the least, you need to have the center of gravity pass behind the hip and in front of the knee. And that's another important concept. And you can see it for yourself. If you're standing straight, you're probably not working your quads as much as if you were trying to walk or stand with your knees flexed 10, 15 degrees. And there's 3 sets of muscles that help to keep that center of gravity behind the hip and in front of the knee. And there's the hip extensors, the glutes, the quads, and the gastrocs. And so this is kind of that kind of concept where your center of gravity is, behind the hip and in front of the knee. And the second picture here sort of tells you, like we just mentioned, if somebody's got a hip flexion contractures, one way to compensate is with increased lumbar lordosis. And again, this is about the quadriceps demand. It's been well studied, and you can experience it clinically too, that if somebody's got a flexion deformity at the knee, they really have to work their quads hard to do the same amount of work. And a very classic example, which we don't see in this country that much, but if you guys are doing overseas work, etc., you will see some patients with polio or some young adults who come in with residual polio deformity. And this is a great example of how a lot of these children and adults will have no quadriceps function, and yet some of them can stand and walk. And that goes back to the same principle of having your center of gravity behind the hip and in front of the knee. And a lot of these patients will compensate. And one very subtle way of compensating is that they'll have this hand-to-thigh gait. And you've probably seen some of these patients or pictures where they're either walking with their hand in their pocket trying to thrust their knee back, or actually having their palm on the front of the thigh. The other thing they can do is they can hike up their pelvis with a hip extensor. So a lot of these patients have absolutely no quadriceps strength. They have 0/5 quadriceps strength, but can still walk if they've got good hip extensors and no flexion deformities at the knees. So these are little concepts that you can keep in mind. Switching to sort of the more bread and butter stuff about deformity assessment, which is the radiographic evaluation. But again, the bottom line is that you cannot just use the x-rays in isolation. Just like Dr. Birch mentioned, you got to examine the patient first, get the whole picture, and then put the x-rays as part of that clinical assessment tool. And again, like John Herzenberg said, there's no point in memorizing and measuring all these angles if your x-ray is not done right. So you got to make sure your x-ray is appropriate, and on the lateral view, you just want to see that the two condyles are almost overlapping, not truly overlapping, and the back of the fibula, the fibula is just behind the tibia. So just like with the frontal plane, you have the sagittal malalignment test and the sagittal malorientation test. And if you get a x-ray with the knee in full extension, in almost all of us, and if you drew a line from the anterior cortex of the femur, it should probably be in line with, or collinear with, the anterior cortex of the proximal tibia, give or take 5 degrees. So that's a good starting point if you can get an x-ray in full extension. And the malalignment test will tell you whether there is or there is not malalignment. But it's honestly not as strictly adhered to in the sagittal plane as it is in the frontal plane. But it is important to measure all these malorientation angles. And again, it was mentioned by the previous speakers, and I'll just go into it in a little more details in terms of, these 3 angles for now. And we'll stick to around the knee and a little bit the ankle. The PDFA, what is the PDFA? Somebody want to take a shot? What does that stand for? Posterior distal femoral angle. And the next one? Perfect. And awesome. Okay. And you compare it to either the contralateral limb, assuming that that's normal. And if that's not available or is abnormal, then you can use the population reference values that are well outlined by the Baltimore group. So just, again, to reiterate, so it's all down and there's absolutely no question in your mind, and you're going to go home and do this all the time. So for the femur, you draw this line along the mid-shaft of the distal femur and a transverse line along the physeal scar in a kid or along the joint in an adult. And normally this angle should be, as John mentioned, 83 degrees plus minus 4. So if that number is less, let's say it's 70 degrees, what kind of deformity is that? Procurvatum, exactly. And let's say it's 95 degrees. Recurvatum, perfect. So, again, no magic here. Same thing, PPTA. And honestly, a lot of these anatomic axes, especially for the tibia, is how you would put a tibial nail in. I think a lot of the residents are so familiar with, intramedullary nailing of the tibia that that's where the starting point of this line is. If you want to put a nice nail, you don't start in the middle of the tibia, you start kind of in the front, right? So your line is at the junction of the anterior 1/5 and posterior 4/5, and you just draw it along the mid-sagittal plane of the tibia, and that angle, which is a 10-ish degree slope, is 81 degrees plus minus 4. And again, a lower number is procurvatum, bigger number is recurvatum. And very similarly, the ADTA, which is 81 degrees. And if you don't want to remember these 81 and 83, at least for the tibia, you could just be safe if you said 80 degrees. You remember one number, say 80 degrees, PPTA, ADTA is 80 degrees, and you wouldn't be that wrong. And 83 degrees for the femur. So really you just remember three numbers, 87 on the frontal plane, LDFA, MPTA, and on the sagittal plane, 80 for the tibia, 83 for the femur. And you're there. Okay, so goals of preoperative planning, and again, this is both for frontal, sagittal, and axial. You want to identify all deformities, the site, the plane, magnitude, direction. And again, the Baltimore group has a great course, so if you want to go into more details, you could go there. You can always read the book, but this is just an overview. And the concept with preoperative planning is, you've seen how we've got these lines, and it's sort of color-coded. The one line is, let's say, red, the other one is blue. At the end of the exercise, you want those two lines to be one line. So we'll show you some examples of that. And just as a very simplistic overview, these are the questions you want to answer in the sagittal plane. Is there sagittal malalignment? If there is, where is it coming from? Is it coming from the diaphysis? Is it coming from the metadiaphysis? Is it coming from the joint? Is it coming from the soft tissues? And then just because it's there in one site doesn't mean it couldn't be there in another site. So you just have to, answer those questions. And those extra 5-10 minutes spent on the front end with preoperative planning is going to save you a whole lot of trouble at the back end. So, just to show an example, this is a child with Blount's disease, and you can see in the picture on the left has procurvatum deformity. So the PPTA is going to be what? Less or more than 80? Less, right? Okay. So I'm just going to take you a little bit to the next step, is how to plan for an osteotomy. So one thing you can do is, what the normal value is. You know where that line starts, right? So it starts at the junction of the anterior 1/5 and posterior 4/5. You draw the tangent to the tibial plateau. You draw this proximal axis line. Then, you draw your distal axis line. And what's the goal? The goal is that the red and the blue at the end of the exercise should be one line. It's that simple, right? So if you were to do your osteotomy here, you would not need to do any translation, right? Because those two lines will become one. The further you move away from that apex or the cora, the more you'd have to translate the distal fragment. Let's say if you were to do the osteotomy here, what would you need to do other than just angulate? Anybody? You'd also need to do what? Yeah, you need to move that distal segment anteriorly, right? So sometimes because of anatomic constraints, let's say there's an apophysis that's open here, you cannot do an osteotomy here, you do it here, so then you've got to build in a little bit of translation. It doesn't matter if you do it acutely, gradually, etc., but that principle needs to stay in mind. So that's sort of what we did, and then you can see it's collinear. Okay, so, and again, in general, you want to plan and have a problem list, just like Dr. Birch said, you got to look at the whole patient. See whether they have just a deformity, whether they have a leg length problem, is there growth remaining, et cetera, et cetera. And there's many different ways to plan osteotomies. You can do it on a sheet of paper. You can do it on the X-ray. You can do it on PACS. You can do it with any software. But the principles really don't change. Methods of correction, I don't think I'm going to go into it too much, but suffices it to say that just like we've identified that the deformity can come from bone and soft tissue, the treatment can be bony and soft tissue, right? Soft tissue things could be as much as, physical therapy, stretching casts, splinting, or soft tissue releases of different sorts if there's a contracture. And sometimes you can cheat, and if there's a soft tissue problem, you can create a bony solution to that, and vice versa. So this is another few case example. This is a child with fibrous dysplasia with, multiplanar, multi-apical deformity. Again, those are terms that you'll start to get familiar with, that, he's got two sites of deformities, and it's not just in the frontal plane, but also in the sagittal plane. So, many solutions. One is to do, like they talked about the Cora, so you can do a two Cora solution. So he's got two sites of deformity, you can correct both, and then put an implant there. So it's not all about just one implant or one Cora solution for every patient. This is a patient with Blount's, and since we're just focusing on the sagittal plane here, you can see the PPTA. He's got bilateral Blount's. His PPTA is less than 80 degrees. He's got procurvatum bilaterally, and you fix him not just from the front, but also from the side. So you can see, and again, once you start looking at these patients, you'll realize that they do have a procurvatum deformity, and you can straighten it out. This is a more dramatic example of a heavier kid with Blount's, but again, the principles don't change. And I mean, that's actually what's attractive here, is that even if it's a 5-degree problem or a 55-degree problem, the principles are pretty much the same. So here's a more severe deformity, and you can do many different ways. I actually don't pre-construct the frame as much anymore, but you can pre-construct the frame based on, your deformity analysis, put it on the leg, and achieve a pretty decent result. This is even a more dramatic example of how things, need to be done right the first time. Because once you're dealing with iatrogenic issues, you're dealing with broken hardwares, more iatrogenic problems, etc. So this is a 22-year-old male who has had, I think, 8 or 9 surgeries on each leg before, broken hardware, underlying diagnosis of Blount's, and severe varus and procurvatum deformity. And I think this case is interesting because once we straightened him out, we actually didn't try to lengthen him. We just straightened out his varus and his procurvatum. And look at the difference in his leg length. So that again shows you that if you've got a flexion deformity and you just straighten it out, you can gain a lot of length if you're doing, let's say, a gradual opening wedge correction. And then the other thing here is you need to appropriately translate, because just like we showed with the other case, that since the apex was up here and we're doing our osteotomy a little distal, you need to appropriately translate. And if you keep that concept in mind, that you start with a red and a blue line to do where you want things to be, and then you cut the bone and you make those two lines one. I mean, that's a very sort of basic concept that seems to work. It's relatively simple, straightforward. Doesn't matter which plane you're looking at. You start with two lines and you make them into one. And that'll, in itself, if you keep that in mind, automatically, wherever you do your osteotomy, it'll necessitate, how much you're going to translate and in which direction. Now, back to polio, because I think it's a fascinating disease, especially the orthopedic problem. So this was a 25-year-old immigrant who I saw with polio, and he was wearing KAFO, had a hand-to-thigh gait, and really wanted to get rid of his brace and wanted to walk straight. He had good hip extensors. So if you look at his x-rays, he'd previously had a tibial osteotomy, and if you look at his numbers, his PPTA on the right side was actually, what does that show? Does he have recurvatum or procurvatum? He already has some recurvatum. But if you look at him clinically, he's flexed. So if you drew that line, that anterior femoral line and anterior tibial line, he's got a flexion deformity, right? He already has recurvatum there. Most of the flexion problem here is soft tissues. But that's where I said you can cheat a little bit. And rather than going back and resecting all the soft tissues and still not getting, a good outcome, you could, and this, by the way, is his opposite side, you could do a distal femoral extension osteotomy. And you could do it gradually, which is, I think, is safer, or you could do it, acutely as well. And so he was very happy. He didn't have to use a brace. He didn't have to use, his hand to push his knee back. And that, again, goes back to that concept. Remember we said, if you can get your center of gravity behind the hip and in front of the knee, your quads don't have to work as much. So he had 0/5 quadriceps, but he could still walk without a cane or a brace because we could realign his center of gravity in front of the knee. Now, this is a more subtle case, but just tells you that you do have to, look at things three-dimensionally. This was a 14-year-old patient who about a year ago had a distal tibial Salter II fracture, which we had fixed, and she started complaining of anterior knee pain. And if you look at it closely, I don't think I could blow this up, but this was a Harris growth arrest line. And what do you see here? Sorry, say it a little louder, please. What do you see? Yeah, partial growth arrest, right? Well, firstly, compared to the other side, it's subtle, but you see here the tibial apophysis is open, here it's closed, correct? That's her opposite side. And you can see this is the Harris growth arrest line. You've got a little bit more space in the back than you have in the front. So although subtle, it's telling you that she's got a partial growth arrest anteriorly and she keeps growing in the back, right? And that may be a generator of patellofemoral pain. She absolutely didn't want more sort of, when I talked about fixator, etc., she's like, I don't want that. The family didn't want it. Her leg length discrepancy wasn't that great, but she was still growing. Her PPTA, of course, was 90 here and 80 here. So she had a 10-degree of recurvatum, which was enough to give her some patellofemoral symptoms. So you can sometimes use guided growth, although in this case, I guess people could argue that it didn't do as much. But the concept is that you can use these plates or drill bits, etc., to preferentially, just like you do it in the frontal plane, you can do it in the sagittal plane. And so in this case, we try to address both the LLD and the recurvatum by, on the right side, putting the plates more posteriorly and putting it in the mid-sagittal plane on the other side. So whatever growth she has left, she doesn't, she doesn't get more of a limb shortening there. And you can argue, is this the only treatment? Absolutely not. You could have done 5 different things here. Another thing, you just, especially in kids, you just have to keep an eye on the follow-up. So this was a 5-year-old pedestrian, stuck, had this Salter II fracture, which was fixed. If you were to guess what deformity he would get, or would he be prone to in the sagittal plane, what would you think? Would he get procurvatum or recurvatum, and why? Huh? Recurvatum? All right. And why? Right. Okay. Your concept, your second part is absolutely right. But, and again, this is not part of this course, etc. But you can also look at where the Thurston-Holland fragment is, right? See, the Thurston-Holland fragment is anteriorly. So that part of the growth plate is actually protected, right? So so that's another little side thing, that wherever the Thurston-Holland fragment is, most of the time the growth plate under that is protected. So sure enough, he didn't follow up for 5-6 years, and then he had a procurvatum deformity. So something else to keep in mind. Now this is an interesting patient. Was a young adult who, as a child, had a femur fracture and was treated with a tibial traction pin. And I think the tibial traction pin was placed a little too anteriorly, and she had a recurvatum deformity here. Now, what's interesting is, and I'm not trying to make this up, she was booked by a sports surgeon for a PCL reconstruction because she had a posterior sag. So this is where I think it's important that even if you're not going into pediatric deformity, et cetera, whatever you're doing, I think it's important to kind of take home at least the basic concepts of how to look at the x-rays, how to measure angles. So she would have had a PCL reconstruction had somebody else said, well, why don't you go get a second opinion? So, so you just have to measure these angles. You can see she's got this recurvatum. And interestingly, just like we'd mentioned earlier, because this happened at an earlier age, the distal femur tried to compensate a little bit So her PDFA showed a little bit of, procurvatum of the distal femur, but not enough to compensate. So she underwent, and she was short. She was short about 4 or 5 centimeters. So again, same concept, osteotomy, lengthen, little bit of translation, and realignment. Now this is an interesting case. This was an 80-year-old patient who came in from overseas, had an open injury, no fracture, but he was a pedestrian sitting behind, actually not a pedestrian, he was behind a motorcycle and had a deep abrasion to his distal femur and had a physeal injury to the perichondrial ring. And they kept doing these osteotomies for recurrent varus. And he ended up with severe shortening, a fused knee, and lousy skin there. So, we corrected him with a 2-level osteotomy, straightened him, lengthened him. I was feeling very good about this. And then he came back and he's like, I can't play soccer because I'm always leaning forward and my hip hurts. So although he looked good on the frontal plane, if you look at it on the sagittal plane, I didn't correct I gave him an iatrogenic, recurvatum at the knee. So we ended up, and he was a little short there, so we ended up, straightening that out, and which helped. And had I been more careful and cognizant, looking at things 3-dimensionally, I probably could have gotten a home run first time. I think I'm going to skip this because time's running out. But I'll just show you this. So a lot of times it's not just the bony problem, but the soft tissue problem, and that needs to be addressed with a soft tissue solution. This is a patient, had AVN, had this Elizarov pelvic support osteotomy, actually did quite well, but she wouldn't go for therapy, and she did have a lot of surgery. So bottom line was, despite attempts at physical therapy, she was stuck with very limited knee flexion because her quads had been bound down to the femur. And so we did a Jude cordyceps plasty and got her knee moving, and she had a good outcome. And finally, again, you have to look at where the problem is. So here the problem is not in the bone. This is a 14-year-old patient who had a cyst in his cervical spine, has a Charcot knee, and had a posteriorly dislocated knee joint. So here the problem, you don't really want to create a bony solution to this soft tissue problem, and it is a tough problem. So we try to gradually straighten him out. So in closing, I think, this is a great sort of start for everybody to sort of start thinking about it, the deformities. And if you really want to get more into it, I think the course that we talked about, the Baltimore course, is great. You could become a member of this society. As a candidate member, you can get more into it. And back to the sagittal deformities, you don't want to ignore the clinical exam. I think that's where it all starts. And get adequate x-rays before you start measuring all these angles. And, as Dror's going to talk about that, the osteotomy principles, if you're doing an osteotomy away from the apex or the cora, you just have to think about translating, and just very commonsensical things. That, if it's a growing child, you want to look for recurrent deformities. You don't want to just straighten it out and say goodbye. Don't be too greedy. Sometimes you've got to, back off a little bit and say, well, we can do the lengthening or the deformity correction in a staged fashion. And don't forget the forest for the trees. Thank you.